Good morning, GLODERM family. It is so lovely to see so many great conversations and so many wonderful people here. As anybody who knows me, they know I'm a little bit of a stickler for time. And so we are going to get started because we not only have our wonderful GLODERM family who is here in person, we also have a virtual audience who's participating. So I want to give a warm welcome to all of you who made it to Denver and are joining us here to kick off the American Academy of Dermatology with the GLODERM meeting. This is by far one of my favorite activities of the entire AAD, and it's so special and wonderful to be able to start with all of you. I also want to give a warm welcome to our virtual audience members. People are joining from all across. Oh yes, give them a round of applause. I love that. For virtual audience members, because they're joining us from all over the world, you will be able to participate and have some conversation with us via chat. We are monitoring that while you all are here virtually, and of course in the room if there's going to be some questions as well. Our session is shaping the future of global health dermatology. We're going to do a little welcome. Here's just a little general overview for the morning. If you hadn't seen the agenda, we have two sessions, session A, then a break, and then session B. Session A is going to be the skin health resolution. Really exciting to talk about from the road from adoption to implementation. A lot of momentum and excitement around this. Our amazing speakers who we'll be introducing shortly. Then we'll have a short break, and during that break we're going to get a group photo. So we're going to just come right out here to the center area, so don't run to the bathroom quite yet. Let's get a group photo, and then you'll be able to do that. And then session B is going to be advancing global skin health equity, and we have another amazing group of speakers who are going to be participating. After speakers talk, we're going to ask you to come join us up here at the table, and then we'll do a Q&A from that as a panel. So if you run away, I'll come grab you as well. Now, all of the scientific session wouldn't have been possible with our amazing scientific committee. So I want to give a huge round of applause to all of these individuals, many of whom are virtual, but a huge thank you to the time and effort of finding these amazing speakers and putting things together for that. Many of them are virtual. Dr. Olafolukami Kole is on her way, and so she's going to be introducing and chairing the second session, but really a lot of gratitude for the time, energy, and planning into this wonderful meeting. And then also want to give a huge round of applause to our speakers. So I'll give a big round of applause here. You'll be seeing them momentarily as well, and we'll give them a lot of applause for that as well. And so without further ado, I want to introduce our first speaker, who is Dr. Claire Fuller. She really needs no introduction in the global health dermatology space, but I will still introduce her because I think that's the fair thing to do. She's a consultant dermatologist from London and is a medical dermatologist with an interest in infectious disease, neglected tropical diseases, all of the above. She is the chair of the International Foundation for Dermatology, which is the foundational arm of the International League of Dermatologic Societies, and it was one of the founders of GLODERM. Everybody in the room knows her. She's an amazing connector, mentor, person, and we're just so delighted that she's going to talk to us today. So please welcome her to the stage.
Thanks so much for that welcome and introduction, and I am technically incompetent, I will just confess. So, yeah, what I was going to try and do this morning is first of all say, well, welcome to you all. There are some new faces here that we don't recognize. So could you just stand up as if this is your first attendance at a live GLODERM meeting? Really pleased to welcome you all. So you're joining a family. You're joining a family, and we just really, really welcome you to join with us and work with us and make global health dermatology a reality. So while that slide's up, you'll all no doubt be reaching for your QR code and all of that sort of thing. But you probably all know it perfectly well by now. So what I just really want to work on this morning is to acknowledge that it's a real privilege to stand here today as one of the founders of GLODERM. But not only that, but to someone who's witnessed our shared frustration as a community move towards a shared purpose and now into a shared global influence. And I think that's really, really something. Last year together, and it was everybody in this room, it's everybody who's been working for skin health. Last year we achieved something really historic with the awarding or the adoption of the World Health Assembly recognizing skin disease as a global public health priority. And this is not just a resolution. You know, it's a recognition, it was validation, and most importantly, it's a mandate for action. And today I want to talk about really what comes next, because this is our moment. And from resolution to realization is what we now need to really focus on being about. We're in a rare and powerful policy window. Now, you may think this is all going to sound like policy bollocks, but I just want to stay with me on this. But I think the understanding the rhetoric is completely helpful and thinking about it. But we know that whilst a policy window is lovely and open at the moment, providing political recognition, global visibility and momentum, it's also, they don't stay open forever. And if we don't move decisively, we do risk this window closing and this resolution just becoming a well-worded thing that fails, a commitment that fails. So we want to translate this into real change for our patients. And so the question is not what we have achieved, but what will we now do to deliver the resolution recommendations. And the resolution gives us three critical things. It gives us a legitimacy. Skin health is now no longer peripheral. It gives us leverage. We now have a platform to engage with ministries and funders. And it gives us alignment, a shared global direction into conversations about universal health coverage and clarification of how to ensure that the workforce structure is appropriate and skilled in skin health management. And this we'll do by targeting frontline healthcare workers, community healthcare workers, but also emphasising that each country is going to need a specialist leader to instigate these training initiatives and maintain them. And we've got a mandate to have conversations with our ministries about the access to essential medicines for skin disease and legitimacy to encourage specific surveillance of skin disease, which we haven't had before. But a resolution alone doesn't change systems. Political will only matters when it becomes system change. So let's talk about implementation gaps. If we don't address system constraints, the resolution remains rhetorical. We must now translate policies and political will into policies that are implemented, systems that function, and services that reach people. And crucially, outcomes that reduce inequity, because the patients we are serving, for them, nothing has changed yet. And we all know we work in areas with weak primary care systems, with dermatological shortages, limited essential medicines access, and fragmented disease-specific efforts, and also huge data gaps. So if we are going to move forward, how do we do it? How do we organise ourselves? It's a huge task. I'm suggesting three pillars. We focus our work around integration into primary care, ensuring access to essential medicines and diagnostics, and making sure that we have the tools to measure the burden and the impact of what gets done. So let's look at pillar one. Most global diseases, let's face it, are managed outside dermatological clinics, and if we design for specialists, we'll fail. If skin health remains specialist only, we will fail. So we need to equip our primary healthcare providers, we need to enable task shifting effectively, consider useful algorithms, practical algorithms, and expand teledermatology support, because integration is not just efficient, it's the only scalable path to equity. And we've got evidence that we're having some success, and you'll all be aware of initiatives that you're involved with where we're doing and starting to implement some of the resolution recommendations. And the WHO Skin NTD app, which was built through partnership with many outside stakeholder partners, as looking at really effective field work, showing it's a useful tool, and it's also responding to recommendations for example, including epidemiological context and potentially linking people directly, linking frontline healthcare workers directly with experts, and potentially moving from a teaching tool into a diagnostic support tool, but some way away, and it is underway and in place and fit for purpose. Moving on to Pillar 2, essential medicines and diagnostics. So access is not just about price, it's about inclusion into procurement systems, because diagnosis without care and treatment is just not real care. So we need to assure that we align with the World Health Organization EML, but also that national systems do the same, and make sure that this is affordable and practical. And there is, again, some success in this. Just a few months after the WHA resolution was published or adopted, in September, the new EML list came out and incorporated 3 key areas for skin health. Biologics for psoriasis, for the first time, were included, emollients for atopic dermatitis, and sunscreen for people with preventing skin cancer in people with albinism. And that inclusion has been effectively trumpeted and amplified around the world and continues to do so, and is being talked about at national level. So let's move on to Pillar 3, the data. So if we can't measure it, ministries don't prioritise it. We know what we don't measure is not prioritised. So what we really need to assist in effective measurements and collecting effective data is really good standardised case definitions, classy burden estimations, robust mechanisms for understanding workforce density, as well as competent access matrices and metrics, and critically, measurement of stigma and lived experience. Because skin disease, as we know, is not just clinical. It's social, psychological, and economic. And our data needs to reflect that reality in order for skin disease to get the attention it deserves. The global disease atlases and observatories that the ILDS has been working with and are very proud of have already helped demonstrate the scale of skin disease and will continue to build our knowledge and bolster our communication of burden and impact. Data enabled the resolution, and data will drive implementation. So it's an absolutely critical area of what we're doing. But integration is also key. At ministry level, there's no psoriasis desk. There's a health systems desk. And this is not about building vertical skin health agendas. That's one of our greatest risks. I think we've got to resist verticalization, over-medicalization, and over-reliance on high-cost therapies, and instead really focus on embedding skin health into the fabric of health services and systems. Because integration is how we're going to achieve sustainability of skin health remaining in the public conversation. So the International League of Dermatological Societies rate for this: World Health Assembly Resolution Implementation Task Force, the WARI Task Force, is focusing on being as practical and in supporting this implementation as possible. We're coordinating implementation support, aligning stakeholders, developing guidance, facilitating country engagement, and also creating shared metrics. And when I say we, it's still open to be joined. As far as I'm concerned, the WARI Task Force is the stakeholder community that's got the energy to provide expertise, commitment, and help us move these areas forward. And there's lots of places that you can contribute if you wish, and I welcome more of you to get involved and come alongside. I'm getting better at asking you, but if I don't ask you, ask me. And we continue to build the team. So what would success in a low-resource setting look like in the places that we work in global health derm? we might see skin integrated into primary care packages, essential topical therapies effectively and reliably available, really nice referral pathways for complicated cases detailed, and community health worker training modules really effectively implemented, as well as skin diseases included in national programs, whether that's non-communicable disease, female obstetric and pediatric health, stigma and disability, to just name but a few. But we do have some risks, and I think thinking about being honest about those is important to do. I've mentioned verticalization being a concern, and fragmentation. If we keep on duplicating pilots, there is a fragmentation that goes on. So thinking about how we share what we're doing, share best practice, and amplify and multiply good programs is going to be key to getting our services out there in a more effective way. And we do want to make sure we're not actually recreating the inequities that we're trying to resolve. So what do we need to do next? So I think this is not really, maybe it's about reframing, not thinking it as just a dermatology project, but it's a health systems project. And to achieve this effectively, we're working on aligning our messages. We're working on sharing implementation tools. We're working on avoiding duplication, ensuring we scale up successful pilots and share good practice, and engaging ministries, most importantly, and lead and provide the implementation research needed to demonstrate the way to move forward. So we're moving from projects to systems. So think a little bit about aligning messages and sharing implementation tools. So just as an example, the Global Access to Skin Health Observatory, which was launched just a year or so ago, and is collecting data from all of the national leaders around the world, according to the building blocks of the health systems designed by the WHO. It's been incredibly successful at reaching large proportion of the world, and will publish this year on these various metrics of what the access to skin health looks like across numerous topics. And we are looking forward also to this live interactive Data Explorer website where each country would be able to go in and look at their data, to question it, to modify it, to contribute to it. But this is going to be the live repository that will continue to demonstrate what we do and demonstrate impact. So this is really exciting. We now have an implementation tool that we can share, and that will hopefully go live this year. That's right, Esther, isn't it? And thank you to all of you who are involved in that. A major achievement. We know the patient voice is pretty critical. How long am I waffling on? You're doing great. Okay, fine. We know the patient voice is really, really critical, and patient voice is important for the design of our programs, but we have shown in advocacy how having them with us is totally critical for the powers that be, the political leaders, to hear the situation. And they have produced the International Alliance for Dermatology Patient Organizations, Global Skin, have produced this super patient-reported outcome measure, which is validated across all skin disease and can be very useful at producing robust patient-reported measures. So what about engaging governments? I'm sure you've all got examples, and there's some really high-level ones, but just the most recent. So back in February, the European Academy of Dermatovenereology advocacy group have managed to convene and involve and get happening a meeting actually in the European Parliament entitled More Than Just Skin, where under the hostage of some Polish ministers of health in the European Parliament had held a discussion around turning global commitment on skin diseases into policy, not only at EU level, but also nationally. Now, I don't know very much, well, I didn't know until I went there in February, much about the EU and what it might achieve. I still don't think I'm any the wiser, but I think it's better that we were there than we were not there. And I think having the conversations and starting to move out from those relationships is critical. And at the coalface, you don't see it initially, but it's working on those political relationships and moving them on to policy that we can then move them into implementation. And just 2 weeks ago, we had a workshop on the resolution in Sri Lanka alongside the International Congress for Tropical Dermatology, which was very powerfully attended by the Sri Lankan Ministry of Health, who were sharing with us very proudly their strong mandate, their strong record of public health leadership, which we rebutted with, well, great, you've got this strong leadership in public health. Let's look at these various elements where we could actually bring skin disease alongside what you're already doing and ensure that it's embedded within your already successful programs. And the presenter, the representative from the Ministry of Health, gave a talk where he has effectively done that and committed to that for the next policy round for Sri Lankan health ministry documents. So this was really, really encouraging. And that's what we are finding. They have listened, not all of them, but some have listened, and they're already pivoting and responding to the recommendations of the World Health Assembly. So what about training frontline healthcare workers? Now, I think, can you do a drum roll, do you think? You do a little drum roll? Thank you.
Of course.
Thank you. We're really pleased to launch here the ILDS Dermatology Training Hub. Now, the idea of this global platform for education is designed and targeted initially for frontline healthcare workers. So these are not dermatologists, these are people who are basically seeing patients at the front line, hosting a suite of simply written brief courses, which when they complete online, they get a certificate that they've completed it. And it's designed for common skin diseases, skin NTDs, and is using, and we're working with the World Health Organization NTD department on this, and we're hosting their courses as well as any new that we commission, any ones that you think should come alongside. And the aim is they're all up there, about 30 or 40 courses there at the moment, already many translated into local languages, but that can extend. And the beauty of this is that we can extend into really many different languages. When we were working just with the WHO, we were limited to the 6 official WHO languages. We can move outside that. So this is really exciting, and you can join for free. There's the QR code to get you to it. And just have a little look. Absolutely flexible to receive your feedback. We've just got it out there because we wanted to get this going. We've had some help to fund the launch of it and the platform itself. And the content will be provided by all of you. So we continue to want to build that with our priority aim initially being the frontline healthcare worker. But there's nothing to stop you in the future saying, we've got one, for example, for wound care, but that's again for the frontline healthcare. There's nothing to stop you saying, I would like something really specialist for one particular area. We could ideally host that, say, for skin cancer prevention in people with albinism. You could imagine hosting a program on there for that. So here we are. We're at the end. We've got political will. We've now got global visibility. And what determines whether this changes lives is whether we build implementation architecture together. So let me end with this. Resolutions create impact, and resolutions create mandate, and systems create impact. And we've done the tough work of advocacy. Now comes the arguably much harder work and more important work of implementation. Because the Alliance was never about just dermatology. GLODERM's about equity, partnership, and global solidarity. And if we succeed, we will not only improve the skin health outcomes, but we will reduce inequity for millions of people worldwide. And that is a legacy worth building, and thank you very much for your attention. And I leave you with this really brilliant logo thing I've been playing with. So, thanks.
Well, wow. I feel like what an amazing way to start the morning. I have a gazillion notes, and I'm hoping that you guys have a lot of questions and thoughts and ideas, everything from the training hub to the patient resource tools to the integration. I felt like so many of those themes, I think, probably speak to a lot of things that we're doing and a lot of ways that we can be involved. So I'm certain during the question and answer period, everybody's going to have a lot of different questions about how you can be involved and join the task force and all the different things. Thank you so much. We are going to shift to our next talk, which is a video, which I'm hoping our AV people will help. This is going to be delivered by Dr. Cyndy Muliro. She is one of our GLODERM mentees, who is basically right now a consultant dermatologist in Kenya at the Mama Lucy Kibaki Hospital. She would be here in person, but she's actually one of the ILDS outreach efforts for migratory health work in Kenya, and because she's there, it was really important to be there for part of the team, so we're going to miss her desperately from not being here in person, but appreciate her talk. She does a whole variety of things and is really passionate about global health dermatology. She has interest in hair disorders, dermatosurgery, and community dermatology, and one of the projects that she's working on as a result of her mentorship program and her passion has to do with integrating, improving access to dermatologic care within Kenya using community health workers, education, and teledermatology. So if I go to the next slide, will it play?
Hello everyone, my name is Cyndy Muliro and I'm excited to be taking you through improving access to skincare in Kenya, bringing the resolution in practice. I'm a consultant dermatologist and venereologist working in Kenya at one of the public hospitals in Nairobi, namely Mama Lucy Kibaki Hospital. I am passionate about global health dermatology, and I'm privileged to have been part of the GLODERM mentorship program. I was part of cohort 2 of the program, and this picture here is of me and my fantastic mentor. I'm so grateful for the relationship we've been able to cultivate and all the guidance that she's been able to offer me alongside other mentors in the GLODERM family. And I am truly grateful to be part of this family. Kenya as a country is bordered or surrounded by very many other countries, including Somalia, South Sudan, Uganda, Ethiopia, and Tanzania. We are very well known for our fantastic coffee and tea exports. And if you want to see the big 5 animals, you're welcome to Kenya. You'll definitely see them on our safari. And we are lucky enough to have a park right in the middle of the capital city. So if you're in the capital city of Kenya, that is Nairobi, feel free to take a safari in the national park that is just right there. We are the only city in the world that has this privilege. We also have beautiful white sandy beaches with very clear water. So if you're thinking vacations, if you're thinking sandy beaches, clear waters, the Kenyan coast is definitely worth it. And of course, we are known for our marathon running abilities. We win those medals and smash those records. And yes, that is Kenya for you. About dermatology in Kenya, we have a population of about 56, or rather slightly above 56 million people, according to the last census that was done. And we have a total of not more than 30 dermatovenerologists in Kenya as a whole. So that means we have a ratio of about 1 to 2 million per dermatologist. So that is 2 million people per one dermatologist. I think we will all agree that this is a gross underservice to the people. And to make it worse, most of us dermatologists are actually based in the big cities, that is Nairobi, Mombasa, and the likes. So it's not easy to find dermatological services in the rural areas. More so in the public facilities. On the other hand, we might be able to get dermatology services in a particular center, but the healthcare workers in that particular facility might not have the knowledge to treat dermatology cases. We have a huge knowledge gap amongst healthcare workers in terms of management of dermatological conditions. And this is based off of our even basic trainings. Most trainings don't focus on dermatology. So you find that after graduation, most of us are actually managing these patients blindly. So this means that patients are mismanaged, patients receive delayed diagnosis, and this leads to disabilities, stigma, and preventable deaths. So we set out to try and alleviate this in our capacity. We thought about a 3-pronged approach, where first of all, we offer specialized dermatology services to patients in areas with no access to a dermatologist. We also offer basic training of dermatology conditions to frontline healthcare workers. This is in areas where they have no access to dermatologists. And last but not least, for the purposes of sustainability, we have initiated a teledermatology service. We set out to our pilot site, which is Samburu County. Samburu County, that is highlighted there in red, is approximately 20,000 kilometers square in size and has a population of slightly above 300,000 people. This is an area that is predominantly dry. That means they have very few days of rainfall in the year. And usually their main source of livelihood or their main income, what they do mainly is pastoralism. This is livestock keeping. That means they're always moving around. And historically, like all the other arid and semi-arid areas in Kenya, they have historically been marginalized. This includes having challenges that are focused on food. They tend to experience a lot of drought. There is limited access to health and even educational services. So in Samburu County itself, there is no dermatologist, there is no clinical officer dermatologist. So that means these areas that I've circled here are the big cities that I was talking about. And this is where you have most of the dermatologists focused or clustered around. So this is Maralal, which is the capital city or the capital of Samburu County. So you find that patients come from all over Maralal, and the road networks there are not really the best, and connection is not the easiest. So you find that so many patients have to travel more than 300 kilometers to be able to access the nearest dermatology services, which is quite unfair to say the least. And access to this area is mostly by road. So we set out to implement our project. First of all, we wouldn't have been able to do it without the grant that we have received from CeraVe. So we are very, very grateful to CeraVe for the access grant. This has been enabled us to really take care of the logistics and to be able to ensure that we're able to take services and deliver this dream to the people of Samburu. We were also able to talk to the local pharmaceutical companies where they provided us with free medication that we could offer the residents of Samburu. So we treated them and also offered them free medications that had been donated for free also to us. We went ahead and talked to the county government of Samburu under the leadership of the County Director of Health, Medical Services. And we were able to meet the county health management team, and we shared our proposal, and it was very well received, and they really facilitated us in implementation of this project. We also needed the healthcare workers who will be part of the trainings and also part of running the outreach clinics. And they were more than ready to learn, more than ready to receive, and more than ready to even participate and treat their community. Last but not least, we really did a lot of community mobilization. This was done by the CHPs. These are the community health promotion officers. We really are grateful for the work that they are doing and the work that they have done. They were able to educate the patients about skin diseases, about stigma in relation to skin diseases, about even the availability of this treatment. And more so, they were even able to do crowd control for us on the particular day of the outreach. We also had a fantastic team of specialists, and that's we were able to take all the way to Samburu, and they saw patients and also treated these patients, and also assisted in delivering the lessons to the healthcare workers. So we had an inception meeting, first of all, where we went and met the county directors, the county health management team. Here we laid out our proposal, we laid out our project, explained what we intended to do, expected outcomes, and they were very receptive and very supportive, and actually were very instrumental in ensuring that there was smooth running of the activities in that week that we were actually there. So very grateful. This team was being led by the County Director of Health, that is Dr. Ezra, who was very instrumental also in facilitating how we can go about this whole camp and everything that we set out to do. We started off, first of all, with training of the frontline healthcare workers, because the thinking is we want them to be able to learn and get the basics of dermatology. Then after this, they'll be able to see patients with confidence. So we train the healthcare workers on basic dermatology topics. We started off with description of lesions. We went ahead and also taught them about history taking in dermatology. We went ahead and taught them about the basic identification of lesions, identification of basic diseases, management of these diseases, and also when to refer and when to manage and when to discharge even patients from dermatology clinics. Here is a photo of the healthcare workers after finishing the training. They were very, very happy and excited. Then we went on after the training, which we did. We went on now and started the outreach clinic. Now we were participating, or we were doing this outreach clinic with the healthcare workers that we trained. So in every room where there was a specialist seated, there were some healthcare workers who were part of the classes where they were seeing the patients with the dermatology specialists alongside the healthcare workers that had been trained. So when doing this, we were able to also teach them while on the job, not just classroom teaching. Yeah. So we found that this was very effective, that it had a lot of retention, it had a lot of benefit, particularly for the healthcare workers. They were very confident when it came to diagnosis of these conditions and even management of these basic conditions by the time we were finished with the clinic. The most common conditions we saw included atopic dermatitis. There was a lot of atopic dermatitis. We saw pityriasis vesicolor, we saw tinea capitis, acne vulgaris, contact dermatitis, urticaria, lichen planus, impetigo, scabies, vitiligo, keloids, and there was also a good number of chronic ulcers. Of note is we were able to identify a pocket of onchocerciasis. Patients coming from a particular area had symptoms of onchocerciasis. This has since been taken on by the county. They have written a proposal in regards to the same, and also are working towards mass treatment and mass elimination and eradication of the same. So this project was a good thing. It's good that it happened. They were able to identify that this is a problem, and moving forward, we are able to manage even these patients better. Part of the implementation also included support from local pharmaceutical companies. So we were able to receive from a company called KLM, another one called Hazela, and another one called Damol. They provided us with a lot of moisturizers, emollients, steroids, antifungals, antibiotics, antihistamines. We had a full functional pharmacy that really, really benefited the people of Samburu, and they were actually very, very grateful that they were able to receive these medications, because for some of them, they're not even able to get medication. You might write for them the prescription, but the ability to be able to get the medication is also another problem. So this was very, very kind of these pharmaceutical companies, and we are hoping that we'll continue with this relationship even for future camps. We also went ahead and initiated teledermatology services. Good thing is Samburu County already has existing telemedicine services. So we are coming in to just strengthen what is already existing there. They have telemedicine available for other specialties. So we are coming on board to join the dermatology team. So they're able to see patients. We taught them how to take good photos in good lighting and to also give good history. So as they upload these photos, they also upload them with a good history. We're able to discuss sometimes via WhatsApp calls. Sometimes we do live consults with the patients. And this has proven to be very, very helpful, especially even in following up the patients that we had admitted in the wards and things like that. So this has been a very positive and very helpful tool towards sustainability of this. We're also able to offer them free licenses from Visual DX, where this is both a reference point for them and a learning point, I think, because they're not just able to get differentials from the app, they're also able to get notes that they can read about the disease, and also notes that you can share with the patient. So I believe this is quite helpful for this team of people. We also conduct monthly virtual sessions. The team suggests, or rather the frontline healthcare workers suggest a topic that they feel is challenging. We prepare the presentations. These are done by specialist dermatologists, and we take them through these classes for just an hour. We go through a discussion, we talk about a case, we show them photos of these lesions, particularly in our skin types, and they're able to now identify and further manage these patients. We are grateful because through this project, we've been able to bring dermatological services closer to our people. There's been more awareness about skin diseases, about stigma that surrounds skin diseases, and about the availability of treatment of these skin diseases. Many people did not know that some of these diseases are actually treatable. We are also grateful that we've been able to empower the healthcare workers in the management of dermatology conditions. I wish you could see how confident they were and how happy they were that they're able to identify a particular condition, they're able to treat the patient, and the patient comes back and they're okay. They are very, very happy about that. And through teledermatology services, we have been able to ensure this continuity of care for the patients. And this means that there is no breaking or follow-up for the patients. Patients are adequately followed up. In case anybody is stuck, there's always somebody who is ready to assist. And all in all, and I think most importantly, we now have much better patient outcomes when it comes to skin disease. In Samburu, skin disease are actually amongst the top 4 health conditions that are a problem in Samburu. So you can imagine if you've been able to deal with one of the top 4 issues, this means this county is miles ahead in terms of management of health access, and healthcare, especially in terms of dermatology. We are hoping to have more collaborations in future and have more people on board, that is more organizations joining us, and definitely more suppliers, that is medical suppliers who can be able to sort us out with medical equipment, with pharmaceuticals that we're able to give to these patients when we see them. And we are hoping to engage more county government so that we can have this project spread out, more widely spread out, not just in one county. And hopefully we'll be able to also work with the Ministry of Health directly, because working with the Ministry of Health directly means also we'll be able to work with the counties even better. And last but not least, you and me, fellow global health dermatology advocates, we need you. We need you in Kenya. Please feel free. You're more than welcome. We are happy to have you. We are happy to have you treat us and help us to be able to improve access in dermatology care in Kenya. We are grateful for GLODERM. Thankful because I'm part of this GLODERM family. Because without GLODERM, I don't think I would have been able to get all these networks, all these connections, and even this kind of information, and even access to the grant application. I'm grateful for CeraV for helping us with the grant, for giving us the grant and enabling us to carry out all these logistics. None of this would have been able without the grant. We are grateful for local pharmaceutical companies, namely KLM, Hazela, and Damol, that were very instrumental in giving us a lot of medication, a lot of free medication in order to give the people. We are grateful for the county government of Samburu for their support, for allowing us to do this work in their county. Of mention is Dr. Ezra Lekinit, who is the County Director of Health Medical Services. He was very, very instrumental in ensuring that all this came to happen, all this came to pass, and I just thought that he needed special recognition. The frontline healthcare workers of Samburu were amazing. They were very receptive to knowledge. They were very receptive to education. They were so positive, and actually, they were so happy. They danced after the trainings, after the classes. That is how happy they were to get this knowledge. So, very grateful to the people, or rather the frontline healthcare workers of Samburu. Very grateful to community health promotion officers led by James. They were so instrumental, so instrumental in calling people, in mobilizing the community, ensuring patients came, ensuring patients understood what was happening to them, and also very instrumental in crowd control during the camp. They were extremely helpful. I'm grateful for the team of specialists that came along with me, that is Dr. Karen Waithera and Dr. Maria Kindi, who are very helpful and instrumental in both training and treating of patients. Grateful for Kari, who is my mentor. I wouldn't have done this without her guidance, definitely. And last but not least, the people of Samburu. We were able to see more than 600 patients. We were actually able to see a total of 657 patients over 2 days. So we are grateful that they showed up, that they came and sought treatment and got the help that they deserve. Thank you very much. Asanteni sana for listening. Thank you very much.
Well, thank you to Cyndy. We'll give her a big round of applause. Wherever you are in Kenya and the world, we'll see if she's able to join at all for the Q&A period or not. But if not, I know she's very open to having different questions. I think she is a great example of how putting things into action and a great little playbook for how you can incorporate some of the things. And I know Claire's already having her wheels turning about what we can do for you to use this as an opportunity to help others set up similar programs. Now we're going to move from our skin health needs in Kenya we're going to go to incarcerated populations in Australia. It is my pleasure to invite Dr. Georgia Pace, who is a rural New South Wales or Australia general practitioner with a strong focus in skin health for rural and Aboriginal communities. She's working towards a career in dermatology, which I learned is even more chaotic than a career in dermatology in the US, so congratulations to her for that, and has an interest in improving equitable access to specialist skincare for people living outside major cities where distance-limited local services significantly affect health outcomes. So it is our honor and our pleasure to welcome you from all across the world to be here today. So thank you. Help me warm again.
Thank you everyone for having me. It's wonderful to be here. So good morning, my name is Georgia and I'm a proud Aboriginal Wiradjuri woman from a small place called Geary in the outback of New South Wales in Australia. So I'm currently in training for general practice, but I have the ultimate dream of becoming a dermatologist one day. And I'm currently holding a research position with the Justice Health and Forensic Mental Health Network of New South Wales. So it's with that position that we have conducted the research that I present to you today. So just before I begin, I'd like to acknowledge the traditional owners of the land on which we gather today, the Arapaho, Cheyenne and Ute people, who are the traditional owners of the land of which is now called Denver. And I'd also like to acknowledge the traditional custodians of Australia, the Aboriginal and Torres Strait Islander peoples. It is their land of which the research that I'm presenting to you today is conducted. So I'd just like to honour all First Nations people in the room today. So I should introduce you to my wonderful team. So first up we have Dr. Julia Bowman, she is our research manager, then Dr. Reem Zeki, our senior research officer, myself there in a lunch break during general practice, and then wonderful Dr. Dana Slape, who is my supervisor and mentor. She is also a senior staff specialist dermatologist at both Campbelltown Hospital and the Justice Health Network. So just to give you guys a little bit of geographical context from the land down under. So on the right we have Australia, and all the different colours are mapped out all of the Aboriginal nations that make up Australia. So there's over 250 of them, and they all have their own culture, their own communities, their own law. It's all very complex, so you can imagine that makes both social and health interactions quite complicated sometimes. And then zoomed in on the left, we have zoomed in of New South Wales, and the big orange section in the centre is where I come from, Wiradjuri country, and that's what we call Central West New South Wales. So it's a regional rural area, not a major city, there's not much out there. So in terms of healthcare, we're quite limited, and especially for something like dermatology, we are extremely limited because most of our dermatologists are located on the east coast, where the cities are, like Sydney. So the populations that I'm talking about today, before they enter incarceration, they already are disadvantaged in terms of primary healthcare access, but also specialist healthcare access. And it's not just dermatology, it's all specialty healthcare providers we're limited in. So we're disadvantaged before we enter an even more disadvantaged population. A little bit more context. So on the right, this is close to where I'm from, where I live. So there's 2 jails in this picture. There's Macquarie Jail and Wellington Correctional Centre. And these are located in Wellington, New South Wales, not Wellington, New Zealand. So you can see surrounded by red dirt, out back it's farming country. There's not really much there. And then on the left, we have the inside of Bathurst Correctional Centre, and that's about a 2-hour drive from Wellington. Okay. So really important to acknowledge the people who make up this data. So quite significant and unfortunate stats here on the screen. So starting from the left for you, 30% of Australian prisoners identify as Aboriginal or Torres Strait Islander, and that's really significant because we know that Aboriginal and Torres Strait Islander people only make up 3% of the general population of the country, so it's quite a significant stat. Aboriginal people are 13 times more likely to end up incarcerated than their non-Indigenous counterparts. And we know that, unfortunately, 57% of New South Wales juvenile justice detainees identify as Aboriginal or Torres Strait Islanders. So again, our youth highly likely to end up incarcerated. So our study, what did we do? This is a sub-analysis of the people in the New South Wales prisons. So we extracted all the dermatology conditions which were recorded in the electronic health system for all the people who entered the 16 prisons in New South Wales from 2015 to 2024. So about 10 years worth of data, and the data was collected one of 3 ways. So first of all, it was either self-reported at reception and then confirmed by a clinician. Second, it was diagnosed during their stay. Or third, it was self-reported by the patient but hadn't yet been clinically confirmed. Our total cohort over the study period was over 66,000, and we've built a catalogue of over 460 individual dermatology conditions, and we've organised them across 13 different categories. And this is a brand new classification system which previously hasn't existed in Australian custodial settings. So our headline stat, 3,112 people, which is 4% of everyone who entered a prison during that time in New South Wales, had at least one dermatological condition recorded. And when you're looking at those numbers, 4.7% seems really small, but I'll just get you to hold on to that figure and we'll come back to it as to why it's probably not a true figure. So when we break down the people who are making up these numbers, it's quite alarming. So you can see in the top bar, Aboriginal women have the highest prevalence of any of the groups, and 7.3% for Aboriginal women, non-Aboriginal women 6.9%, Aboriginal men 4.5%, and non-Aboriginal men 4.2%. So for us, 2 things to highlight here. Number one being that women across both groups, non-Indigenous and Indigenous, have significantly higher prevalence than men, and that warrants further investigation and further targeted care. And second, Aboriginal women at 7.3% have almost double the rate of non-Aboriginal men. And when you consider the barriers to reporting conditions and treating them, the gap is probably much larger than that as well. Okay, so what conditions did we actually find? So skin cancer clearly dominates, 397 people with non-melanoma skin cancers and 202 with melanoma. So we have over 600 people with a malignant skin disease, and this is probably due to, in Australia, we have a high UV burden, and living in New South Wales and in the type of place that we live in, it's an agricultural society. People are living outside, sun protection's not always happening, and there's no health literacy education about this stuff. It's a little bit lower than in other parts of the world, put it that way. So second, we have psoriasis at 317. And for a chronic relapsing condition, in a place where we don't have good access to dermatologists, many of these patients probably weren't diagnosed or seeking treatment before they entered custody. So already disadvantaged before they enter prison, and then we're getting these numbers. And I'll touch on again later, the numbers are probably much higher than what we got. And eczema and dermatitis came in third at 277. And then, interesting, we also have syphilis with cutaneous features at 192, which is showing us a significant burden of STIs in the population, which isn't unexpected. But it's just a reminder to train our clinicians to be aware of the systemic symptoms of STIs. And again, something that we're trying to highlight is that all of these conditions are manageable, but they're manageable with access to dermatology, which is what we don't have. So this is our framework for categorising all of the conditions. So we have 13 different categories. The three largest patient groups were inflammatory conditions, malignant cancers, and infectious conditions. The infectious category spans across bacterial, viral, fungal, parasitic diseases, which reflects the unique transmission environment of being inside a prison in a way that probably doesn't translate to people who are living outside of a prison. So the risk factors of being in prison are obviously quite different to someone who's not. Okay, so our unique risk factors for being in prison, obviously there's overcrowding. So cells are designed for sometimes 1 to 2 people, often 3, 4 or more people can be designated to a cell. Prison tattoo culture, we know that it exists and it's widespread, and we're seeing cellulitis, abscess formation, bloodborne infection risks increased. And among skin problems alone, we have mental health risk factors which are compounding the skin diseases that we're seeing. We have self-harm, excoriation, and hygiene neglect, secondary to psychiatric illnesses, which all contribute to the burden of the data that we see. So we've broken the barriers down into 2 categories, being systemic and patient-level barriers. So in terms of the systemic barriers, I've already harped about no specialist dermatology outreach in most New South Wales facilities. Transport and security makes things difficult. If you need to take someone to an outpatient appointment, for example, formulary restrictions, poor clinical handovers, especially at release. If someone's been identified as having an issue in prison and then they're released, the follow-up care is usually non-existent. And obviously shortage of trained staff within the system. At the patient level, we have stigma, especially around STI-related issues, low health literacy and poor treatment adherence. And this is something that I've seen a lot myself working in the region of New South Wales that I do. Health literacy is quite poor. In Australia, we have a tremendous distrust of health services amongst the Aboriginal population, and that is because of our history of colonisation and what the system did to our people. So there's an enormous barrier for Aboriginal and Torres Strait Islander people to seek healthcare. Mental health comorbidities and cultural barriers, again, particularly around our Aboriginal and Torres Strait Islander population. Okay, so I wanted you to hold on to this number because I think it's important that we acknowledge why it's probably a significant undercount. So first of all, the recording bias. So unless a patient reported the condition themselves or the symptoms, or it was noticed by a healthcare practitioner within the system, it didn't end up within our electronic health system, and that's where we got our data from. So, for example, the numbers for acne were really quite low, and I think it was 45 in that whole number. We could probably all assume that it was much higher than 45, but it probably wouldn't come across a patient's mind to tell someone who could then document it, I have acne. Same way if someone had chest pain and they also had acne, the triaging nurse probably wouldn't document acne and then it gets pulled from the data. So second, the health literacy and social determinants, patients' ability to identify and articulate this and seek the skincare needs that they need. The cyclical care pathways, so nurse review to another nurse review, eventually a GP, a long wait for a derm referral, it can be months to years where we come from, may never get a diagnosis, lost to follow-up, transfer of systems, transfer of prisons, release, things just don't happen. Triage priority, something like a skin condition will always lose out to trauma or something more acute. And rural and Aboriginal compounding disadvantage, which has sort of weaved throughout the whole talk. But we know that in New South Wales, a lot of the prisoners are coming from the regional and remote areas which are already socially disadvantaged, and then they're ending up in prison, which is even more of a disadvantaged space for you to be in. They didn't have access to dermatology before. They're most certainly not going to get it once they're inside. So our recommendations, we've compiled 6, and I won't walk you through all of them. The slide speaks for itself, but I think the 2 to highlight here, number 4 and number 5. So number 4 is culturally safe practice, and this can be applied to every country. But until Aboriginal peoples in custody can trust health services, and until our clinicians are genuinely equipped to provide trauma-informed, culturally safe care, even the best dermatology protocols will have limited reach within this population. And number 5, the transition of care. So we know that skin disease doesn't stop and start at the gates of prison for people cycling in and out of custody, and we know that once you've been in prison before, you have a higher risk of ending up back there. Continuity of treatment at entry and release needs to be a priority. So I would just like to finish on, I come from the communities that feed into these prisons, and I've grown up with people who have ended up in prison. I've sat with patients who have never seen a dermatologist in their lives, not because they don't want to or they don't know how to or they don't have access to GPs to get them a referral, but it's just because the system was never built with these people in mind. Australia isn't unique to this, as I mentioned, and every country in this room has an incarcerated population, and I hope that today is a reminder that dermatology belongs there too. Thank you.
Well, just another really fabulous talk to talk about, I think, other ideas or playbooks that we can incorporate into many of our communities. Our next speaker is Dr. Jonathan White. He's going to be talking about the World Health Assembly resolution in a global response for skin allergy, which I know we all see. He's an English dermatologist, but works in a French-speaking hospital in Belgium, and he loves many things in dermatology, but has special interest in skin allergy, inflammatory dermatoses, and occupational health disease. He's been a residency or training program director for numerous years and have trained so many different trainees, and has had a huge impact in that capacity. And also is one of our GLODERM mentors and has a huge capacity in the ripple effect, not only for his own individual mentee, but for the other mentors and mentees as well. So we're delighted that you're here to speak. Thank you.
Thanks very much. Ooh. And now for something completely different. So I'm going to be brief because we're already overrunning, and Ankari must be having a heart attack. You okay?
Do you see how calm I am?
But I have no, apart from my academic affiliations, I have no conflicts of interest to declare. So this is all going to be a call to action because we have the World Health Assembly resolution now, thanks to Claire and the team behind her, ILDS and various other people, stakeholders, and the WHO where I work as well. But, this urges the member states. It doesn't really have any legal state there's not legally obliged to comply, but it's another tool that we need to use. And obviously they're supposed to be integrating these skin conditions into national policies and programs and action plans, but it's going to be up to us to help them to deliver that. Claire's already put the QR code for this, but basically the message, and I would advise you all to read it if you haven't already, but it's good skin health for all, for everybody. So today I'm going to talk about allergy provision as part of this WHA resolution, and I'm going to concentrate on type 4 hypersensitivity reactions, and we're talking about various different allergens such as metals, fragrances, preservatives, ingredients of creams, ingredients of cleaning products, laundry detergents, and so forth. And these can have an impact both at home and at work. Usually these allergens cause a dermatitis, not always, and most commonly this occurs on the hands and face. There may be a significant occupational component to this, and sometimes the patients are unable to continue their work and they need to retrain in other industries and so forth, and this can lead to important socio-economic consequences. Generally, this has a significant negative impact on quality of life. And, as I said, the hands are very commonly affected. We've all had a paper cut, which is tiny, almost invisible, but it really hurts. And when you get your keys out of your pocket or you're getting something out of your bag or you're typing on your laptop, it really is painful. And if you can imagine what it's like to have the equivalent of thousands of paper cuts on your fingers every day, for months or years, it has a huge impact on people's lives, even though it may not be so visible. And many clinicians who are not trained or don't have the time to be empathic about this or to listen to the patient will just dismiss this as being unimportant. You're not going to die of this, it's all right, don't worry, it's just going to need a bit of cream. In dermatology, we have very few opportunities to cure people. We can cut cancers out, we can sometimes give antibiotic treatment or antifungal treatments or whatever else and cure them, but this is another opportunity, one of the rare times we can actually cure this dermatitis. We know from Cyndy's talk, we know from Georgia's talk that dermatitis is very important. Probably the global prevalence is at least 5 to 10%, if not higher. And this is a way we can cure this. We can actually identify the cause and they're okay for the rest of their life. Here are some pictures for those who you're probably all familiar with allergic contact dermatitis. We see in the hand somebody allergic to an accelerator in their latex and nitrile gloves that they're using at work and at home. We see an allergic cheilitis due to a lip salve. We see somebody allergic to his eye drops and he's putting more and more eye drops in, thinking it's not improving, I need to put more in, but actually the cause is the antibiotic in the eye drop. And we see somebody with fingertip involvement of pulpitis. This is somebody who's working with plants, Primula obconica in this case, but it could be many different plants. So florists or people working agricultural and so forth may get these problems. So the gold standard for investigation, as you will all know, is for type 4 allergy is the patch test, so epicutaneous patch test, which is done on the back. You see a photo here of some patch test systems. It's quite a complicated procedure, and ideally you need pure standardized allergen preparations for it, because if you don't, then it's very difficult to predict the results. You really need good training of the healthcare worker who's doing the procedure. And it's time consuming. This is delayed type hypersensitivity. With skin prick testing for proteins, for pollens, foods, you get the result within half an hour. With these tests, because it's a T lymphocyte driven process, it will take at least 2 days before you're going to see any results, and the whole process usually takes about a week. Clearly, in some parts of the world, local conditions are very important. And when I was in Kuwait a few years ago, they don't do patch testing for half of the year because it's so hot. Even leaving the building, which is air-conditioned, into their air-conditioned car, they're completely soaked with sweat, and then the patch tests don't stay on, and you get false negative results. So in some parts of the world, you need to tailor your testing to the local ambient conditions. Of course, we've talked today about some settings in Kenya and other parts of the world where, in fact, the cost to the patient is going to be absolutely impossible. In Tanzania, some of the patients can't afford antihistamines, sunblocks themselves for their albinism or whatever else. And these tests are really expensive, and in the States they're really, really expensive. But in Europe, you're talking about 800 to 1,000 euros, or equivalent roughly the same in US dollars. So this is really expensive testing if you're going to do the whole gamut of tests. And sometimes this becomes impossible. And in local conditions, you may need to tailor that to the local condition and do a more limited series of tests to bring the cost down to make it more reasonable for healthcare systems. Ideally, one would keep a database of all the results for audit purposes. If your positivity rate is really high, close to 100%, that means you're being too restrictive in your testing. That means you're going to be missing lots of people with allergic contact dermatitis, which you could identify and cure. If your positivity rates are very low, that means you're being too indiscriminate. You're testing loads of people who don't really need it. So ideally, you want to have your rates about 50 to 60%. So we're picking up the people we need to, but we're not wasting our resources too much. The other ideal thing would be to have a network of competent healthcare workers to discuss difficult cases. And I've been doing patch testing for about 25 years. And I can tell you there are lots of cases I need to discuss with colleagues. And sometimes people listening to the patients, they have brilliant ideas, but medical students, other people, nurses, other healthcare workers, sometimes somebody else will see that thing that you've missed. So again, having this network to discuss cases where you have unexpectedly negative results or a positive result you can't really classify. Of course, in terms of globally, we need to be able to code these allergies so that the WHO and other stakeholders can monitor trends. I'm not going to keep you forever because some of you will know that this is my particular obsession in life, coding. So I'm sorry about that, but I have to say that fortunately in ICD-11, which you don't use it in the US just yet, but we have specific codes for different allergen groups, which means that you can look globally and identify trends and maybe target resources to particular allergens to do primary prevention, which of course is going to be the absolute ideal. So we have this coding tool in ICD-11, which is available offline, and actually many countries in resource-poor settings have actually adopted this already. Oh, I would just say that, and China has really led the world in adopting this, first of all, and India has followed as well. So we've got at least like a quarter of the world covered already. So it's a call to other nations to take up ICD-11. So what about the impact on cutaneous allergy of this assembly? How do we identify these global priorities? What do we know already? Well, actually, the short answer is not that much, actually. And the one really good, or the best evidence we have so far, it was published in 2016. Some of you may know Luciana Tano, who's actually originally from Brazil, but works in France now. And this was published in 2016. There were 47 countries that were sampled here, which sounds good, but actually there are 193 UN member states. So and maybe the sample wasn't enough. And if you look at the map in the actual paper, many of these countries were industrialized countries, so there are huge gaps across Africa, East Asia, and so forth. But the data they provided is all we've got, so I'm going to present a little bit about what they found. They found that the physician is doing the testing in most cases, sometimes a nurse, less commonly a technician. Many of them had more than 5 years of experience, which sounds good, but of course, just because you're doing it for a long time doesn't necessarily mean to say you're doing it properly. So that's just a little caveat there. Most predominantly worked in allergy because once you get people who are competent, they tend to do it just all the time. And again, that doesn't necessarily ensure that there's going to be quality service, though. In terms of use of guidelines, most people are using guidelines. There was no consensus. Different parts of the world use different guidelines, but actually most of them are fairly equivalent. So I think this is actually a pretty good result that people are following, using and adhering to guidelines. What about the allergens? Well, 30% of people were using commercial preparations only. Now, there is a series of allergens, which is known as the European Baseline Series. This is the type of allergens and the concentrations and the vehicles of the allergens are decided by the European Society of Contact Dermatitis. There's a special committee. I sit on that amongst many other people. And we decide which allergens will go in or go out of the series depending on current trends. Hence the need for global surveillance mechanisms, by the way. 28% of people were using a bit of both, commercial, but also their own preparations. And of course, these own preparations are not necessarily standardized. What do these results mean? Will they give you false negatives, false positives? It's essentially unknown. And 19% of people, for whatever reason, were using their own preparations without any commercial preparations. So we're not sure of the purity and of the availability of these allergens in the patch test system. In terms of what they were using to apply the allergens, well, this was highly variable, and I can tell you there's a huge difference between different adhesive tapes and different actual little units where the allergens are applied, be it aluminium, be it plastic or other things, and it can have a big difference on the results you get. So highly variable. What about the readings? Well, the ESCD recommend doing at least 2 readings, and 70% of people did 2 or 3 readings, which I think is probably good. Some did just 1. In fact, one of them was doing it 20 minutes, which is more for type 1 allergy. It seems strange to me, and 4 readings seemed a little bit excessive, but maybe there was some special reason for that. But the thing that really struck me from this study is that they self-declared side effects of the treatment. The one thing that really I couldn't quite believe it was they were reporting erythroderma in 12% of responses. Now, do they mean erythroderma that I understand being a generalized erythroderma, or do they mean there was a bit of redness when they did the testing, which I can fully understand, and it's going to be more than 12%? Maybe they're testing drugs, which maybe give you more risk of erythroderma, using non-standardized allergens at unusual concentrations, perhaps too high. You're going to get more erythroderma, but this whatever, it seems really high to me. So again, this needs to be, you need to nail down this detail. So the conclusions of Tanno were that the patch testing methodology is variable, it's a small sample, and it's too small, I think, and there are huge holes in global data. And what about the validity of this? And the question is, is doing something better than doing nothing? And we could argue it, and I would say it's not always better than doing nothing, actually, and sometimes better not to do the test if you're going to get the wrong results, and actually can have bad consequences for people avoiding things that they're not really allergic to. So what's going on already in terms of kind of implementing this WHA resolution? Well, there are isolated ad hoc procedures and projects going on throughout the world. I just highlight a few. There are many others, so apologies if there are things I'm not mentioning. But there's a long-standing collaboration between the Gentofte Hospital in Copenhagen, Denmark, which is their national allergy center, with Moshi in Tanzania, and they're producing some great data which will be presented at the ESCD conference in Copenhagen in June of this year. I would invite you all to come. It's going to be a great meeting. There have been isolated collaborations between Dr. Weishar and the University of Mbarara in Uganda, for instance. And I did, well, actually, before Argentina left the WHO, unfortunately, in my opinion, I did a WHO outreach clinic and workshop there in Patagonia last year to try and get some people, local people, to be doing allergy testing, because there's a huge unmet need there. Nobody was doing any allergy testing in that particular part of Patagonia. But how do we tackle this problem at a global level? It's all very well having the individual projects, but how are we going to roll this out? Well, the first thing is identifying a problem, and we're going to be involved with a project which will be modelled on Esther's fantastic work of the Skin Observatory Questionnaire. So we're going to shamelessly plagiarise that with collaboration, and it's going to be coordinated by Dr. Tarimo from Moshi, who's interested in this project, and we're going to be rolling it out. And of course, then the step 2 is, once we've identified the particular gaps, and there are going to be huge gaps in certain parts of the world, it's going to be plugging those gaps and having mechanisms to help, and all of those things I was mentioning about access to allergens, about training people, and about having networks to mentor people in the longer term. So there's going to need to be agreement between and coordination between the World Allergy Organization, ESCD, and other stakeholders about minimum criteria for competency. And this already exists in many countries in Europe anyway. You have to test a certain number of people, you have to have a certain number of training, and you have to undergo maybe some form of exam to make sure that you're actually competent in interpreting these results. And this obviously has to be adapted to resource-constrained settings. And as Claire mentioned in her talk about the Essential Medicines Committee, it's great those 3 things have been added on, but these allergens are considered to be medicines. So we need to make sure that these medicines, these allergens, are available on that EMC list, because then the governments will be obliged to give you access to them. And there are many countries where this is not available, and I can tell you it was a nightmare getting allergens into Argentina. I can tell you over the break if anybody wants to hear the sob story. And of course, we need some sort of formal mentoring of this. And I would also like to plagiarize GLODERM. This is the model that we're going to use to go forward. So the aphorism is, anybody can patch test, but few do it well. But I think if you have a mentoring system, that's going to be, the way forward, really, that you can support other people and help. Because it is difficult, and we all need ongoing CME. So what can you do? Well, you can hopefully join in the fight to get global access for patch testing in the worldwide setting, and contact me with details of who's patch testing in your area. Be active in GLODERM and other initiatives, and think about global skin health for all, and particularly the World Skin Health Day on the 8th of July. I'd like to thank all these people without whom I couldn't have done any of this work, and I'd particularly like to thank the patients for whom we're doing all of this. And please do feel free to email me or discuss with me in the break if you have any questions. Thanks very much.
Lovely. I want to give another round of applause to our amazing speakers. A really great way to tie in the resolution with allergen, everything. So another round of applause for everyone. Woo! Those of you know me, time is very important to me, and we built in some time here, so we're going to use a relaxed version of Carrie to have some question and answer period now. And so I think we've got time for some questions, and then after this we are going to get a photo. So once again, do not run to the bathroom, do not pass go, do not get a snack. We're going to get a photo, and then you can do all of those things. So I want to open up to see if there's questions in the audience. Oh, yeah. Oh. Good. Okay, good. The mic's here on. Oh, could you turn these on too? Yeah. Okay.
I've got a question for Georgia.
Okay.
So it's really exciting and it's amazing data you've produced. I just wonder, I have to declare a conflict of interest that I am very passionate about penal reform. And I wonder what you thought about maybe the best thing we could do is actually imprison fewer people and actually look at other ways of having justice done, because that might sort out some of the problems, the overcrowding, the sanitation, releasing people for appointments and so forth. It doesn't address the underlying problem that you've noticed and you've documented, but what do you think about that campaigning for incarcerating fewer people?
That's a very interesting question, and probably not one that I think I could probably answer. I mean, it would probably be put to the leaders of our countries, but I think, I mean, I spoke about the high rates of youth being incarcerated, and I think that we could start with the youth by not incarcerating such high numbers. Yeah. And maybe reforming our youth before we lock them up. And it's a huge problem in Australia, especially in the Northern Territory. Huge numbers of kids are incarcerated, like under the age of 10. They're locked up and treated like adults. So, yeah, that's a very interesting question.
And whilst the mic's making its way to Esther, I just wanted to acknowledge some very, very key people that we've got in the room. We have, well, he was here. Has he gone? Art Papier was here. Just to acknowledge, Art was here earlier, who was the founder and lead of Visual DX that we have been using a lot in our GLODERM projects. And to also acknowledge the Cerave team who are joining us at the back, who've been so instrumental in getting GLODERM initiatives off the ground, so thank you to you guys. And to finally acknowledge all the people who helped with the slides that I plagiarised. I forgot to mention you in my talk. I'm feeling really embarrassed, so I think there's a sort of Team Esther here who are probably responsible for most of them. So apologies for not acknowledging that.
Hi, Esther Freeman. I'm also very loud. I'm not sure if this is working. Esther Freeman from USA. Thank you guys. By the way, it's collaboration, not plagiarism. We just need to reframe this. And I just wanted to ask a question for Claire, kind of on behalf of a lot of our trainees. I'm so pleased to see so many trainees from different areas that are with us today, and young people really kind of heading into the field of global health dermatology. So I was wondering, Claire, if you could muse a little bit with the World Health Assembly resolution and the WORRY task force for those that are kind of junior and coming through the process. What are things that they might be able to do locally, or ways that they could really kind of contribute to this effort? Thanks.
Well, I think making sure getting alongside us so that we all know what we're doing, and being potentially able to be recruited into rolling out of pilots, amplifying advocacy messaging, helping us doing all the stuff that I don't really understand, which is social media, and basically being young, I think is, we all need, I certainly feel I need a reverse mentor now for being able to be meaningful and effective. And stop being an old fart, So that is a really, really critical role. But what I'm hoping we'll do, and with the help of the fantastic ILDS team who try and wrestle some sort of structure into my night's move ideas, is to have a various playbooks that they can follow and then use to roll out. So, for example, Cyndy's amazing talk that she's just given, there are lots of people who've done. I was just hearing from Dr. Ahmed, who's been doing similar sorts of work in Ethiopia and Burundi. But it would be really great for someone who's thinking about doing that to go to what's the ILDS playbook on setting up an outreach service? What are the elements that you need to have in place? Let's follow through and make sure we've got the community engagement, we've got the local healthcare worker, we've got our curriculum sorted out of what we're going to teach the frontline healthcare worker, we've got the telemedical plan to follow on afterwards. All of these elements that I think be really good, to say that's for an outreach model. And helping write those up, helping to go and volunteer and do new ones and to amplify them. We're just really, one day I hope we'll have enough of an infrastructure to be able to receive your contribution in an effective way. But at the moment we're still struggling with how to welcome and include volunteers. We haven't quite got that process sorted out. So I wonder whether GLODERM, it might be another job for GLODERM, because you guys are the hands and feet of the ILDS, and without all that you do, we can't do it. So it's absolutely critical. So maybe that is the next step, is how do we build our WORRY task force of feet on the ground, the WORRY army? I think that's what we've got to develop, is the WORRY army. But a short answer to that is stay detached. So get the GLODERM newsletter. You can also get an ILDS newsletter. So if you go on the ILDS website, you can actually get that delivered directly to you. It doesn't have to come via your organisation that you're a member of. And apply for DermLink grants and all of the offers that come up with that. That can get you involved in pilots. So that's not I want to be able to offer more, and one day maybe we will, but we just love to have you all joining in as best you can, and we are not using you adequately, but be sure you're doing fantastic work, even if you're doing it on your own and being unrecognised, but you're still doing fantastic work. I hope that gives some direction.
Okay, we have a question back here. Hi, great.
I don't think this is on, but is it?
That's on.
Chris Pachakjian, Michigan, United States. Thank you to all the speakers for great and inspiring talks, and thanks to the whole GLODERM community for welcoming newbies like me into Daylight's Day. Sorry, a question for you too, Claire, about the concept of verticalization, which you were talking about. And I've been thinking about that a lot because it's a trap that you can easily fall into, and I feel like I'm already stepping in trap. But the only way to avoid verticalization is obviously having a horizontal platform, which means something like ILDS, which means something like GLODERM. Could you just expand a little bit on how you think we avoid that? And do we have enough people in the horizontal platform to avoid verticalization? It sounds very abstract.
Well, I think it's a really difficult sort of conundrum, isn't it? Because those of us in the room who are experts in a particular field will be verticalizing, will be absolutely passionate about fundraising for research into that neglected area, and that will continue. So I'm not saying don't do that in academia. I'm saying this is about sort of policy implementing skin health for the world at its kind of most basic. So they're different emphasis, but I think rather, maybe it was a bit cruel, verticalization, whether we call it instead, kind of, if you just notice it, name it, and be aware of it, and just be aware of any interventions you're doing which will be about your passionate, small, it's a big issue, but it's a local, sort of a narrowish issue. Just be aware that you might not, to try and avoid having damaging impacts on everything else that's going on around you in terms of integration, or how can you integrate what you're doing with good practice across all skin hair care. And there's no doubt that we'll all benefit, all avenues of academic dermatology and service dermatology will benefit if we're all working together. And we certainly have had, when we introduced common skin diseases into the skin NTD community, the neglected tropical diseases community have got really nervous that we're going to take all of the funding from NTDs into dermatology. So this is a sort of pushback that we've been getting quite a lot. So it's a sensitivity, but I think it's something that we just need to reflect on. I don't know all the answers, but I think it involves some of us having really good horizontal understanding, but those who are passionate, please carry on with your vertical, but just be aware that we might be pushing back a bit in terms of not wanting to jeopardize the major global impact of getting basic skincare to all at the frontline healthcare worker level.
And then I think we'll have time for one more question. I know I really hate to do that. And I think actually you were probably first, so I'm going to have you pass the mic here. And then if maybe you guys can coordinate. We will still be around. I hate to do it, but I also want to make sure our later speakers, so. I think you have to turn the mic on.
Can everyone hear me?
Yeah.
Okay, did everyone hear what I said prior? I'm happy to.
They can rephrase it too, that's okay.
Okay, perfect. I started to think about the concept of doulas. By a show of hands, is everyone familiar with what a doula is? Mm-hmm. Doulas provide a lot of continuous support for a lot of mothers to help, provide a lot of prenatal and supportive care. So I started to think a little bit about your community, and while you are working to bring the healthcare providers, what do you think about the concept of similar to a doula, a health advocate, and banding your community together to pretty much work towards working with these patients and this population to reduce that stigma and make them feel more comfortable with speaking up about their conditions? How do you think the local community could get involved to help increase people to be more willing to open up and speak up about this?
Yeah, thank you for your question. So Australia already have something in place which is similar to, I suppose, a doula system. So Australia has what we call an Aboriginal health practitioner or an Aboriginal health worker. And they're essentially, they're not a nurse. Yeah, they're not a nurse, they're a community health worker, and they've done some basic training in health, and basically they're often a person in the community's first point of contact for healthcare. And they're more embedded in the community than healthcare workers. So I suppose they're more trusted, and being Aboriginal themselves, because you have to be Aboriginal to be an Aboriginal health practitioner, they're naturally more embedded into the communities and they're more trusted. And then they have a unique link between the patient and then the healthcare facility and the healthcare workers. I have seen firsthand, though, it can get quite complicated. You can imagine that picture of Australia that I showed with all the different regions. There's bickering and feuding between different nations, as well as within each nation there's bickering and feuding, just like in all areas and places. So sometimes it's just cultural barriers and social barriers which prevent people from getting the care that they need. But I think that's a great parallel similarity, the Aboriginal health practitioners and a system like a doula.
I'd just say that the patient advocate is an extremely powerful one, and we use it a lot in neglected tropical disease work. So the podoconiosis clinics in Ethiopia are virtually run by patients who are much better listened to than a healthcare worker. So there's lots of parallels.
Well, what a fabulous discussion. I'm sorry to cut off any questions, but another round of applause for our amazing panel.